Everyone, good morning, good afternoon, and good evening. Welcome to this FIP digital event program. It's my pleasure to be your moderator, and we're going to be talking about World Patient Safety Day and celebrating World Patient Safety Day, empowering pharmacists for safer medication in pediatric and newborn care. Next slide, please. My name is Dr. John Hertig. I am an adjunct assistant professor at Purdue University in the United States of America. I'm also founder and president of Hertig Healthcare Advising. With FIP, it's my pleasure to serve as treasurer for the hospital pharmacy section. And again, I will be your co-moderator for this session today. Before we begin, I do have a few announcements. First, this webinar is being recorded and live streamed via the YouTube channel. The recording will be available on our website at www.events.fip.org. You may ask questions at any time during our program using the question box provided, and that's that Q&A box, and we'll be addressing questions at the end of our program. You are welcome always to provide feedback at webinars@fip.org. And please, if you aren't a member, I encourage you to become a member of the International Pharmaceutical Federation at www.fip.org/membership registration. We're very excited that we're making these programs more accessible to you around the world with a new translation feature on Zoom. Step one to access this is turn on captions. That's that little closed captioning box. Enable the translation toggle, and then choose your preferred language under the My Caption Language selection. Now you can follow along in your own language with live translated captions. I'm very honored to introduce today's program. I will be providing welcome and introduction by my co-moderator as well. We're then going to move on to speaker number one. And that title of that speaker number one program is The Pharmacist's Role in Ensuring Safe Medication Management for Newborns and Pediatric Patients. And we're joined by Dr. Frautja Harkis Idzinga from the Netherlands. Speaker two will be a recorded presentation by Dr. Hossam El-Gnaini, who's the pediatric clinical pharmacy lecturer at Cairo University Specialized Pediatric Hospital in Egypt. And finally, our third speaker is going to be talking about empowering pharmacists for safer medication in pediatric and newborn care. And that's Dr. Petria Kober, who's a professor of pharmacy practice, director of professional workforce development at Northeast Ohio Medical University here in the United States. As always, we're going to leave time for questions and answers, and I encourage your engagement by submitting those questions in the Q&A box. And then finally, we'll have closing remarks as well. The learning objectives for our session together today is first, to highlight the pharmacist's role in ensuring safe medication management for newborns and our pediatric patients. Second, to raise awareness of medication safety risks in newborns and our children. Three, to involve pharmacists in the development and implementation of safety strategies for newborns and pediatric care. And finally, number four, to advocate for greater pharmacist involvement in research on patient safety in newborn and pediatric care. Again, this is our slate of both co-moderators and panelists. I'm excited to learn from them as they share their expertise on this very important topic on World Patient Safety Day today. And it's now my pleasure to introduce my co-moderator, Hanadi Alolomini, who's the unit twin and provision coordinator with FIP, the International Pharmaceutical Federation based in the Netherlands. Hanadi, please take it away.
Thank you very much, John, and thanks for everyone for joining our little event today. I would like to start my presentation with the FIP development goals that launched by the International Pharmaceutical Federation in September 2020, and they are a key resource for transforming pharmacy profession over the next decade globally, regionally, and nationally. And also, they align with the FIP mission to support global health by enabling the advancement of pharmaceutical practice, science, and education, and are set to transform pharmacy in alignment with wider global imperatives, global imperatives underpinning the UN Sustainable Development Goals. They are now also aligned with all our work and inform our direction to 2030. With highlighting the Development Goal 19, patient safety, it targets the workforce and education strategies linked to patient safety mechanism and reducing medication-related harm and practice, and also the patient safety mechanism linked to reducing medication-related harm, quality assurance process, and legislation and regulation. Safety in the development and use of medicines is promoted through the advancement of drug safety sciences also. Now, the FRP patient safety program is a high priority for our profession. Pharmacists and pharmaceutical scientists are responsible for ensuring that when a patient receives and uses medicines, it will not cause harm. The program is closely aligned with the WHO Patient Safety Program to ensure advancing and advocating global patient safety. This program is in line with the ambitions of the FIB DG19 and contributes to the delivery of the other DGs and underpins the FIB vision for equitable access to safe and affordable medicines globally. Now, I would like to highlight some of the key resources developed by the FIP that support pharmacists in advancing patient safety and medication safety. The most important FIP resource here is the FIP Statement of Policy titled The Role of Pharmacists in Promoting Patient Safety in 2020 that emphasized the crucial role pharmacists have in preventing medication errors and promoting patient safety. It also focuses on medication management, advocacy, education, and collaboration with healthcare team. The policy encourages fostering a safety culture, non-quantitative error reporting, and ongoing professional training. The statement of policy serves as a foundational guide, supporting pharmacists worldwide in enhancing patient safety through collaborative and proactive approaches. So for further details, please visit the link on the slide, which we will also be shared in the chat box. For more information and resources on patient safety, please visit our dedicated microsite at patientsafety.fip.org or scan the QR code. Also, to support your continuous professional development, FIP offers SEAL courses designed to enhance pharmacy skills and knowledge. One of the key courses in patient safety is the Pharmacovigilance and Patient Safety Program, which empowers pharmacists to improve medication safety through risk management and effective monitoring. This program, developed by the African Pharmaceutical Network, trains pharmacists in safety monitoring, risk management, and pharmacovigilance principles. Also, pharmacists learn to identify, report, and manage medication-related risks to protect patients at both the community and national levels. Also, for more information and registration, please refer to the course link on the slide, also which we will share in the chat box for your information and reference. For more information and resources on pharmacy provision and partnership, please visit our dedicated microsite or at FIP at provision.fip.org and scan the QR code. Thank you very much, and thank you all for listening. Over to you, John.
Thank you, Andy, for sharing those wonderful resources. I really appreciate that. And now it's my absolute pleasure to turn it over to Dr. Frauke. She is a doctor of pharmacy as well as involved in the FIP Health and Medicines Information section, and she's from the Netherlands, and we're so pleased that she joins us today. And so, Frauke, I'm going to turn it over to you now.
Thank you, John. Hello everyone, good morning, good afternoon, good evening. My name is Vrouwtje Harkes Itzinga. I'm an executive committee member of the FIP Health and Medicines Information section, a member of the FIP Technology Advisory Group, and a member of the Social and Administrative Pharmacy section. My work experience you can see on this slide. When I graduated in 2007, I started working in community pharmacy. From 2009 to 2024, I worked at the Medicines Information Center of the Royal Dutch Pharmacists Association. In this department, I was involved in keeping the information in the Dutch pediatric formulary up to date. In summer 2024, I joined the laboratory of the Dutch pharmacists, where I currently work as a pharmacist and a qualified person. Here, I am involved in pharmaceutical analysis and guidelines for compounding, practical guidelines for compounding, for among others, pediatric formulations. Next slide, please. This presentation was developed in collaboration with my colleague Amy Howard. She's another executive committee member of the FIP Health and Medicines Information section. Amy is an assistant professor at the University of Maryland School of Pharmacy. She completed a pediatric clinical fellowship and works in pediatric gastroenterology, asthma, and transgender care. Additionally, her research focuses on health literacy, medicine adherence, and taste palatability for pediatric formulations. Next slide, please. I have no conflicts of interest to declare. I would like to stress that any views or opinions expressed during this presentation are based on my own professional expertise. These do not necessarily reflect the views of FIP or my employer KNP. Next slide, please. And now I will continue with the topic of highlighting the pharmacist's role in ensuring safe medication management for newborns and pediatric patients. This important topic is addressed by FIP as well. It was addressed during the Congress from this year we had in Copenhagen in the beginning of September, where I had the pleasure of chairing a session entitled Children Are Not Just Small Adults. It is also addressed by the Pediatric Formulations Focus Group of FIP and by the Health and Medicines Information Section's Working Group on Health Literacy in Pregnancy and Pediatrics. I will go into this later on. Next slide, please. Now, I would like to start with a case provided by Amy, who works in clinical practice. She had a patient, a child, who was born at 26 weeks with multiple premature comorbidities. This child needed small bowel, liver, and pancreatic transplants. Now 3 years old, the child presented with hyperkalemia without any underlying kidney condition, and the care team wanted to use a potassium binder to address this. The discharge note said, decant formula using 4 grams of sodium polystyrene sulfonate. The pharmacy received a prescription stating, give 4 grams sodium polystyrene sulfonate daily. The mother was told about putting the sodium polystyrene sulfonate into the formula, but she wasn't taught about decanting, which was the purpose. Later on, the mother arrives in the clinic and describes adding the potassium binder, sodium polystyrene sulfonate, to each blenderized formula batch that runs into the G-tube over 45 minutes. Now this is where the pharmacist can play a role to prevent any medication errors, and I will go into detail into that in the next slides. Blenderized formulas contain a high fiber content. This differs from other formulas and will not decant effectively. The potassium binder cannot bind well and it won't precipitate in the blenderized formulas like the one that was used in the patient. In this case, there is also misconveyed information. The discharge instructions were not the same as the instructions on the prescription and the instructions given to the caregiver. Also, there's a risk of drug-drug interactions here. With inappropriate use, there's a high probability of sodium polystyrene sulfonate, so the potassium binder, binding to and impacting thyroid and transplant medications which the child was using. Also, there was a risk for an adverse drug reaction specific to a brand of sodium polystyrene sulfonate, which was used in this case for bowel ischemia, particularly when administered with sorbitol. Next slide, please. And there were more medication-related issues. There were clinical implications of correcting decanting instructions to the correct use. Because some of the medications the child was using could bind to the potassium binder, the sodium polystyrene sulfonate. Now, if that would have been used correctly, or the mother would use it correctly later on, then maybe the dosage of the thyroid and transplant medications needed to be adjusted, because maybe a higher dose was given because not all the drug was available due to binding to the SPS, sodium polystyrene sulfonate. Also, there was here a potential that hyperkalemia was happening secondary to tacrolimus potassium exchange during a mechanism of action with which dose reduction could address. So if the mother would use the potassium binder for decanting in the right way, then perhaps the dosage of the thyroid and the immunosuppressive therapies needed to be adjusted, and the drug interaction would come to light. Next slide, please. Now, I would like to address some key roles of pharmacists in managing medicines safely for newborns and pediatric patients. Pharmacists could play a role in education of patients and caregivers. I showed that in the example of the case I just told you about, but also pharmacists could educate patients and caregivers about robust safety data for vaccines, and they could address vaccine hesitancy, for example. Pharmacists could also play a role in education of physicians and prescribers. They could create awareness about the importance of differences in pharmacokinetics and pharmacodynamics in small children versus older children and adults. Pharmacists could create awareness about formulation safety and about the importance of choosing the right route of administration. And they could prevent and address medication errors. Next slide, please. So some strategies for minimizing errors during prescribing are, like I mentioned, creating awareness about pharmacokinetics, formulation safety, and the route of administration. This can be done, for example, by providing evidence-based information for prescribers. An example of this is the Dutch Paediatric formulary, in which evidence-based dose recommendations for off-label prescriptions for children are available for prescribers. The Dutch Pediatric Formulary has a collaboration, a consortium with Austria, Norway, and Germany, so it's international already. And prescribers can look into this to find dose recommendations. The dose recommendations are prepared by pharmacists, and then they are discussed in an expert panel, which contains pharmacists from clinical practice and physicians, and then they decide on the publication of those recommendations. Also, prescribing support can be given during electronic prescribing, for example, via a check on maximum dosage. In this case, the computer could give an alert during computerized physician order entry when a dosage is prescribed that's higher than is allowed for the age of the child. But this doesn't check on whether the right dose has been prescribed, but only on the maximum dosage. Next slide, please. Pharmacists can also play a role and minimize errors during dispensing, and some strategies I mentioned here. Again, the pharmacist can play a role in creating awareness about pharmacokinetic differences between young children and adults and older children, the safety of excipients, for example, in pediatric formulations, and the route of administration. As my colleague, Dr. Raj Madam, put it at the FIP World Congress in Copenhagen, pharmacists should act when they are dosing children. And so they should adjust for age, size, and physiology, not just weight. They should calculate the dosage, use science, not guesswork, think about distribution and clearance. And they should tailor the medicines, personalize every dose. One size does not fit all. Pharmacists always should calculate the dosage by hand, the prescribed dose, and have a second check, because making mistakes is human. Also, pharmacists can assess whether the prescribed drug and the dosage form is suitable for the patient, and they can have a look at the drug labeling. It is very important that the dosage is very clearly stated on the label. For example, for oral fluids. If on the label it says the amount of milliliters that has to be administered, and then the next time there's a shortage of the strain the child is using, and for example, preparation is imported via another country, and the strain is different, but the same amount of milliliters is put on the label, then the child will get the wrong dose. So it's very important to make it clear which amount of milligrams, which dose the child really should use. Strategies for minimizing errors during monitoring can also be carried out. For example, tracking of adverse events in children. For this, post-marketing data are needed to be available. Also, an awareness of necessary adjustment in dosage form, route of administration, or drug, according to the developmental stage of the patient, need to be taken into account, especially if a certain drug needs to be used for a long time. For example, if a child starts a drug when it is under 2 years of age and it needs to continue using that drug, then the dosage might need to be adjusted when the child gets older because of developmental changes. For example, the activity of cytochrome P450 enzymes. Next slide, please. Now, how can pharmacists effectively engage other members of the healthcare team? They can provide education on safe medication use. They can provide evidence-based information for other members of the healthcare team. They can bring attention to considering a patient's health literacy and adapt medicines information as appropriate. And they can educate other members of the healthcare team on taste and palatability impact on medicines adherence. If the child really dislikes the taste of the medicines, then it won't want to take it, and it would be very hard for the caregivers to administer the medicines. So it's very important to take that into account. Next slide, please. Pharmacists can also play a role in effectively engaging the families of children. Pharmacists can again provide evidence-based information while taking into account health literacy. Examples of this are from our own country, apotheek.nl, a website provided by the Royal Dutch Pharmacists Association for the general audience, in which recommendations and information about medicines in lay language is available, as well as videos about how to use the medicines. It can be done by comics. For example, our Dutch Medicines Evaluation Board has a comic about vaccines to explain how they work. And also the Travel Grant Award winner of the Health and Medicines Information section makes comics to explain about medicines use for children. And pharmacists can be engaged in the use of social media. Again, an example from the Netherlands, because I'm from the Netherlands, we have the TikTok pharmacy, and there are pharmacy technicians and pharmacists active in explaining about medicines use on social media. Next slide, please. So with this presentation, I have tried to give you an overview about the role of the pharmacist in ensuring safe medication use for children and newborns. If you have any questions, feel free to ask them. And thank you very much for your attention on behalf of the Health and Medicine Information section.
Thank you very much, Frauke, for providing those resources and references in a very informative presentation. And we'll get back to you after all of the presenters for some questions and answers. Thank you very much. It's now my pleasure to now go to Dr. Hassam, who's the Pediatric Clinical Pharmacy Lecturer at Cairo University Specialized Pediatric Hospital in Egypt. Dr. Hassam has submitted a video presentation, and so we're going to turn to that presentation now. Thank you very much.
Hello, everyone. It's truly a privilege to be with you today on World Patient Safety Day, a day that unites us all around a shared mission: protecting patients and strengthening safety across every corner of healthcare. This event's theme is especially close to my heart: empowering pharmacists for safer medication in pediatric and newborn care. It's a theme that not only highlights the critical role of pharmacists, but also brings attention to the unique challenges we face when caring for the youngest and most fragile members of our communities. When we talk about newborns and children, we are talking about patients who cannot speak up for themselves, who rely entirely on us, the healthcare team, to make the right decisions, the right calculations, and to put the right safeguards in place. A single error in this population can have far-reaching consequences, Yet with the right systems, we can prevent harm and ensure better outcomes. Over the next 15 minutes, we will take a closer look at why medication safety in this population matters so profoundly, the specific risks and vulnerabilities involved, and most importantly, the practical, concrete actions we can all take to strengthen safety nets, reduce errors, and build resilient systems of care. This is not just a clinical discussion, it is a moral responsibility. It is about ensuring that from their very first moments of life, every newborn and child receives safe, effective, and compassionate care. So, why is medication safety in newborns and children such a distinct and critical challenge? The answer lies first and foremost in their vulnerability. Newborns and children are not simply small adults. Their physiology, their metabolism, and the development of their organs are constantly and rapidly changing. This means that they can react to medications in ways that are very different and often less predictable than adults. Take dosing as an example. In pediatrics, it's rarely one size fits all. Doses are most often calculated according to weight and sometimes according to age or body surface area. That requires meticulous calculation and accuracy every single time. A seemingly tiny error, just a few milligrams too much or too little, can lead to consequences that are amplified many times in a newborn or infant. This is what makes medication safety in this group so uniquely challenging and so vitally important. The second layer of challenge is the complexity of pediatric inpatient care itself. These patients frequently require high-risk medications, highly specialized treatment protocols, and very close monitoring. The risk only increases when we are dealing with critically ill or unstable patients in intensive care, where timing, accuracy, and precision matter more than ever. This combination, a complex care environment, rapidly changing physiology, and weight-based dosing creates an extremely narrow margin for error. A small slip at any point in the process can carry significant risks. And yet, this is not about pointing fingers or blaming individuals. What we must recognize is that the risks are systemic in nature. That is why the solutions must also be systemic. It is our responsibility to build and maintain robust safeguards, from standardization and double-check systems to technology-assisted calculations that act as protective barriers for this most precious and vulnerable patient. When we carefully examine where errors most often occur in the medication pathway for children, we find several well-defined risk points. These stages are not unique to pediatrics, they also exist in adult care. But here's the difference. In children, the consequences are magnified many times over. A slip that might cause minor harm in an adult can have life-altering implications for a newborn or a small child. That's why understanding these pitfalls is so critical. Let's break them down more specifically. We see dosing errors, incorrect weight-based calculations, or simple but dangerous mistakes in unit conversions, milligrams versus micrograms, milliliters versus drops. Then come preparation errors, wrong dilutions, inaccurate concentrations, or improper reconstitution of IV medications, especially when working with tiny volumes where precision is everything. Next are administration errors, giving a drug by the wrong route, setting the wrong infusion rate on a pump, or even missing a scheduled dose altogether. Equally important are monitoring failures, not checking vital signs closely enough, or overlooking lab values that could warn us of toxicity or adverse drug reactions. And finally, communication gaps, misunderstandings during handovers, unclear or misheard verbal orders, and incomplete or missing documentation. Each of these gaps is small on its own, but together they can create significant vulnerability. And here's the key point. Every one of these errors, if it slips through the cracks, can trigger a ripple effect. What starts as a single miscalculation or omission can escalate into a cascade of harm, a cascade that could have been prevented with the right safeguards in place. When we examine errors closely, it becomes clear that identifying what goes wrong is only the first step. The more important question is why it goes wrong. And here, we must recognize that the root causes are rarely just about individual slips or lapses. Instead, they are often systemic, multifaceted, and deeply embedded in how our healthcare processes are designed. Without addressing these underlying structures, errors will continue to occur despite the best intentions of dedicated professionals. Several systemic challenges stand out. First, there is a lack of suitable formulations. Many essential medications are not produced in child-friendly strengths or liquid forms, forcing pharmacists and nurses to manipulate adult products, breaking tablets, diluting injections, or compounding liquids. Every manipulation introduces risk. Second, staff shortages are a persistent reality. Overworked and fatigued healthcare professionals, no matter how skilled, are more vulnerable to slips and lapses, especially in high-pressure environments like intensive care or emergency units. Third, weak decision support systems compound the risk. In many settings, especially low resources settings, standardized dosing guidelines are not readily available, or electronic clinical decision support tools are either absent or not fully integrated into workflow. This leaves staff relying heavily on memory, manual calculations, or fragmented references. And finally, we face a poor reporting culture. Too often, errors and near misses go unreported because staff fear blame, punishment, or damage to reputation. This not only discourages transparency, but also robs the system of invaluable opportunities to learn, improve, and prevent the same mistakes from happening again. So, how do we move from identifying risks to actually preventing them? The answer lies in adopting strategic interventions, measures that are not just reactive but proactive. These are interventions with proven, measurable impact on patient safety. Importantly, they are not limited to fixing individual errors after they occur. They are about redesigning processes so that safety is built in at every step. In other words, they are system-level changes that make the right action the easy action every single time. Let me highlight some of the most high-impact strategies. First, the use of standardized prescribing orders and order sets for common pediatric conditions. This reduces unnecessary variability and helps ensure that evidence-based, safe practices are consistently applied. Second, centralized IV admixture services. Preparing high-risk medications within a controlled pharmacy environment significantly reduces bedside preparation errors, especially for critical drugs. Third, the practice of independent double checks. Having two qualified professionals verify high-alert medications provides a vital safety net against human slips. Fourth, leveraging technology. Smart infusion pumps, electronic prescribing, and electronic health records with built-in dose checking features give clinicians invaluable real-time support and prevent calculation errors before they reach the patient. And finally, embedding clinical pharmacists into patient care rounds. Having a medication expert at the bedside ensures ongoing review, timely interventions, and a dedicated focus on safety that directly benefits both patients and the healthcare team. It's important to remember that not every effective intervention demands advanced technology or a massive budget. In fact, some of the most impactful improvements in medication safety come from simple, thoughtful, and affordable strategies. These approaches are especially valuable in resource-constrained settings where the need for safety is just as great, but the resources available to achieve it may be more limited. Let's look at some practical examples. First, using standardized order forms or pre-printed prescription sheets helps minimize transcription errors and provides a consistent framework for prescribers. Second, pocket handbooks containing quick reference pediatric dosing guidelines can empower staff with reliable information at their fingertips, reducing dependence on memory. Third, creating clear, visual dosing charts for commonly used medications simplifies calculations, especially in high-pressure situations where time is critical. Fourth, implementing barcode labeling templates for prepared medications enhances identification accuracy, ensuring the right patient gets the right drug in the right dose every time. And finally, a low-cost but high-value solution, regular focused training sessions for all staff. Even short, targeted education on pediatric medication safety best practices can reinforce awareness, build confidence, and foster a strong culture of safety. At the very center of many of these safety interventions stands the clinical pharmacist. Our role is not limited to dispensing medications from behind the counter. Rather, we are deeply embedded within the care process itself. We serve as guardians of medication safety, bringing both clinical expertise and a systems perspective. In many ways, the pharmacist is a cornerstone of safe pediatric and newborn care, and this contribution is truly multifaceted. We serve as clinical verifiers, carefully reviewing and validating every medication order before it reaches the patient. We are systems designers, helping to shape treatment protocols and ensuring that safety features are built into technology and workflow. We act as educators, continuously supporting physicians, nurses, and other colleagues with training on safe medication practices. We are also researchers, generating evidence, auditing outcomes, and advancing knowledge to improve the safety of care. And perhaps most importantly, we are communicators, the ones who connect the dots between different disciplines, ensuring that clear, accurate, and consistent information flows seamlessly across the team for the benefit of every patient. To ground this in reality, let's look at a practical example from my own experience. In a pediatric hospital where I was working, we were facing persistent challenges in two critical areas: IV admixture mistakes and inconsistencies in empirical antibiotic administration. These are both high-stakes aspects of pediatric care areas where even small deviations can translate into major risks for vulnerable patients. In response, we introduced two focused interventions. First, we developed and rigorously implemented standard operating procedures for IV admixture, ensuring that preparation was standardized, controlled, and consistently safe. Second, we established clear, evidence-based protocols for empirical antibiotic use so that treatment decisions were both standardized and clinically sound. The results were striking. We recorded a measurable drop in medication errors associated with IV preparation, alongside a significant improvement in adherence to appropriate antibiotic choices. Together, these interventions not only enhanced patient safety, but also improved outcomes, reduced unnecessary costs, and strengthened confidence in the system as a whole. A crucial question we must always ask ourselves is, are we actually making a difference? It's not enough to put systems in place, we need to know if they are effective. And the only way to do that is through measurement. By tracking specific key performance indicators, or KPIs, we can move from assumptions to evidence, ensuring that our interventions are truly improving patient safety. So, what should we measure? We start by analyzing error and near-miss trends from incident reporting systems, which help us identify recurring patterns and vulnerabilities. We audit adherence to SOPs, making sure that protocols are not just written down, but consistently followed in practice. We measure antibiotic timing, especially in critical conditions like sepsis, where every minute matters. We also count intercepted errors, the mistakes caught by pharmacists, or double-check systems. These are not failures. They are success stories that prove our safety nets are working. And finally, we regularly evaluate staff competence through targeted assessments and simulation drills, reinforcing skills and ensuring proficiency is maintained over time. It's important to recognize that no single hospital, clinic, or healthcare team can solve the challenges of pediatric medication safety on their own. These issues are too complex and too far-reaching. That's why research and collaboration are absolutely essential. By working together across institutions and borders, we can share knowledge, close evidence gaps, and advance pediatric patient safety far more effectively than any of us could in isolation. This means we must commit to active participation in pediatric dosing studies, so we can generate stronger evidence tailored to our youngest patients. By engaging in multi-center trials, we pool data, compare practices, and identify strategies that consistently work across diverse healthcare settings, making our findings more robust and universally applicable. Equally important is empowering pharmacist-led research in medication safety. Pharmacists are often closest to the processes where errors occur, which makes their insights and leadership invaluable in designing new safeguards and protocols. Together, this collective effort accelerates our learning curve, strengthens our evidence base, and most importantly, improves the quality and safety of care for children everywhere. As we approach the end of this session, I want to leave you with something practical, a short, actionable checklist. These are not abstract ideas or long-term projects. They are 5 concrete steps that you can begin implementing or advocating for immediately within your own institutions. Each of these actions has been shown to make a real difference in enhancing pediatric medication safety. Here they are. First, make sure every medication order includes the patient's weight. It is the foundation for accurate pediatric dosing. Second, standardize and use clear, concise labels for all medications to eliminate confusion. Third, strictly follow and regularly audit SOPs, especially for high-risk processes like IV admixture. Fourth, establish or strengthen near-miss logging systems so we can learn from close calls, not just from actual errors. And finally, champion the integration of a pharmacist on daily patient rounds in pediatric units, ensuring expert oversight at the bedside. These 5 actions may seem simple, but their impact on safety can be truly profound. So, in conclusion, the message I want to leave you with is both clear and powerful. Safe care for every newborn and every child begins with safe medicines. This is not optional, it is our collective responsibility, and more than that, our ethical imperative. Every safeguard we put in place, whether it's a new SOP, a standardized label, or even a simple double check at the bedside, brings us one step closer to ensuring that the most vulnerable patients in our care are protected. Together, these actions form the foundation of a safer, stronger healthcare system for children. Before I close, let me briefly share a resource that reflects this commitment in action. I founded Samra PH to provide clinicians with free, practical pediatric tools and calculators designed to support safer medication practices. From dosing calculators to IV admixture aids and antibiotic protocols, these resources are openly accessible, and some are even open source so institutions can adapt and enhance them. The aim is to make safe, evidence-based practices more achievable for every pediatric care team. Thank you for your attention and commitment to patient safety. I welcome your questions and further discussion. You can find my contact details and LinkedIn profile here if you'd like to connect. Hello, everyone.
Thank you to Dr. Hossein for what was really a nice presentation. And although recorded and he's unable to be here live, his passion for safe pediatric and newborn care is certainly apparent. So we really do appreciate that contribution. Next, it's my pleasure to turn it over to Dr. Patria, who is professor of pharmacy practice, as well as director of professional and workforce development at Northeast Ohio Medical University here in the United States. So with that, Patria, I'm going to turn it over to you.
Yes, thank you so much. So, just to tell you a little bit about myself, I am a trained pediatric clinical pharmacist with 20 years of experience in the hospital setting, both within pediatric surgery, primarily pediatric intestinal rehabilitation, and the neonatal intensive care unit. I have transitioned to more of a teaching role in the last year or so, but I have been a teacher throughout all my career. And primarily, I teach clinical skills, neonatal and pediatric pharmacotherapy, nutrition support, as well as women's health. And probably the biggest thing that I serve as is an advocate for improving pediatric pharmacotherapy education. So, what is our true problem? And I think many of the different speakers have made us aware of this, but really, If you think about the newborn period and our sickest of the sick in the hospital setting in that neonatal intensive care unit, they're 8 times more likely to experience medication errors even than their adult counterparts in an ICU. And really, even more so, they're more vulnerable to severe errors. And if you look at this, 74% of medication errors are due to prescription errors. So, how can we help that? Additionally, if you think about the therapies that we actually use in these settings, there's some that are pretty high alert medications. A big one that's often reported for various medication safety processes is the use of parental nutrition. It is a focus of numerous international organizations that are trying to improve the prescribing, ordering, administration, and monitoring for these patients. And oftentimes they emphasize neonatal and pediatric patient populations because there is such a issue in that group of patients. And pharmacists can play a huge role in this. And one of the studies that is listed here in 2021, the American Society for Parenteral and Enteral Nutrition actually conducted a safety study with one of the major providers of parental nutrition that's outsourced in the United States and found that a pharmacist makes a huge impact in this population and specifically pointed out the greater number of interventions that had to be made in the neonatal and pediatric populations. So, as a pharmacist, what can we do to keep our neonates and pediatric patients safe? So, I came up with a few ideas here and I have some information to reflect on these. So, as pharmacists, we're important in the process of standardization for many of the processes that come into place. We're also huge in the process of education that not only includes the caregivers of these patients, but other healthcare providers, as well as the community at large around us. We need to show people the true value of what the pharmacist brings to the table. And then I encourage everybody to get highly involved in various organizations and really promote advocacy of the profession as well as our patients and their caregivers and those needs. So, in first discussing more about the importance of standardization, I think a very good representation, and I could have presented for hours on all the different studies that are out there for how pharmacists have made an impact on all these different areas. But one that I selected was from 2023, and it showed the role of pharmacists in standardizing and implementing neonatal continuous infusion concentrations within an electronic health record. This study was done in the United States, and I found this one to be really interesting because they were basically trying to decrease the number of dispenses a pharmacist would have to do by improving concentrations so that you could actually bolus or give a immediate dose for the patient from their continuous infusion. And they saw through standardization that they were actually able to do a 31% reduction in the number of times that they needed to change the concentration, make it appropriate for this bolus dose by coming up with a better standardized concentration that could do both the continuous infusion as well as the bolus. This helped get the medication to the patient faster because the nurse didn't have to request other doses. And the pharmacist did not need to prepare a bunch of different doses that potentially may not be needed for that patient. Other things that can be done are increases in education. I find that to be one of the biggest things that pharmacists end up doing oftentimes, and found this study from 21, also in the United States. And it was basically an urban academic level 3 NICU within the United States. So pretty much takes about everything that can come in the NICU, but doesn't do surgical things oftentimes or have the specialists that sometimes you see in a freestanding children's hospital. But this population was very much served by Medicaid. So that would be our universal form of healthcare for children and women who do not have those resources. And I think what was very important with this, and basically they were trying to increase and improve the timeliness of hepatitis B vaccination. And within this multidisciplinary team, they charged the pharmacists that were with this group to serve as the champions of their new PDSA or Plan, Do, Steady, Act cycle to improve the awareness of guidelines. They found that the pharmacists served as the best small but consistent team who participated in daily rounds and actually then dispensed the vaccines. And I found this to be the case oftentimes in the NICU. The attending physician or provider would frequently change every week or every couple of weeks as they moved between clinical experiences, research, and were in the clinic setting. But the pharmacist was the one that was there week in and week out and could provide this needed information. So they served as the champions of this team, helping to provide everyone with education, targeting any legal and institutional barriers to administration, and improve the electronic health record to support this process. And in this, they were actually able to decrease or improve the time for the hepatitis B vaccination so that now the majority of people were not outside of the guidelines and were actually able to decrease the timeliness from 3.5 days to zero point 0.3 days for our larger patients and from 6 days to 1 day for our smaller patients. And then these patients who actually went home without receiving the vaccine was greatly decreased. So again, what are some other areas of reduction? So wanted to broaden my scope to consider other groups and other populations. So found one in which in Australia, the pharmacists were actually tasked with doing medication reconciliation programs. This was done in a women's and children's hospital. And over a 12-month review of this program, they actually found that by doing med reconciliation of the moms when they were admitted to deliver, they were able to resolve over 80% of the situations due to this process. And it was primarily related to either omission or untreated conditions, oftentimes with these being related to over-the-counter medications, which are not typically considered in the inpatient setting always. So really important in that scenario. Now, many of my examples so far have been with our patients at the youngest part of their lives, but this can happen anytime. So we looked at a study in which we talked about zero medication administration problems and those errors within a pediatric ICU. And basically, within a multidisciplinary quality improvement team, they initiated 5 of those PDA cycles and were able to monitor medication error rates. And within those, they were able to determine that the interventions that reduced medication errors the most were implementation of an information technology system involving the pharmacist in medication management. So we're like the linchpin or the key step in the process, as well as enhancing teamwork, communication, and collaboration. So, what about the value of the pharmacist in other areas? So, I found actually a study in China showing a reduction in unnecessary antibiotic exposure for early onset sepsis. I know we've done this a lot within the United States, but good to see this done throughout the world. And basically, the pharmacists developed, educated, and supervised an implementation of an early onset protocol for sepsis, and it occurred in 2 phases. First, they were actually able to decrease the antibiotic rate from the first phase of the implementation, but even further through the second phase of the implementation. And the days of therapy per 100 patient days went from 30.8 to 28.3 after that first phase to 24.8 after that second phase. More importantly, they were actually able to see a decrease in multi-drug resistant organisms related to this. So from 48.2% to 45.5% after that first phase to a decrease of 37% after the second phase, which was statistically significant. And despite the fact that they were giving less antibiotics, there was no difference in safety outcomes related to it. So there wasn't an increase in later complications due to missing cases of sepsis. So, last, how can you advocate for the patients that you have? I really say get involved. Get involved in an organization. I don't have time to highlight every organization that is possible, but I did want to mention a few that are prominent in the United States in particular. So we have the Institute for Safe Medication Practices. We have the Pediatric Pharmacy Association, which actually has partnerships with both the American Pharmacists Association as well as the American Academy of Pediatrics. And then, most importantly, the International Pharmaceutical Federation, which you are attending one of their digital events today. So, in thinking about these different organizations, it's important to know where they come from. So, the Institution for Safe Medication Practices is a nonprofit organization which is dedicated to preventing medication errors. It is considered the gold standard for medication safety information and actually has an error reporting system for medication errors. Oftentimes, they're able to demonstrate and show errors that have been reported to them and share those with us as pharmacists and healthcare providers so that we're more aware of what is out there. So they're usually the first one to let you know what's going on so that you can implement it and improve it in your own practice. I find this to be extremely beneficial because this organization was actually founded by a pharmacist, Michael Cohen. He founded this group, and more importantly to us as pediatric pharmacists, it's currently led by Rita Ju, who is a pediatric pharmacist. So she understands our struggles that we face each and every day and is very in tuned with what we are dealing with as pediatric pharmacists. When in 2020, the Institute for Safe Medication Practices joined with the Emergency Care Research Institute. And so this institute is devoted to evidence-based healthcare that's safe, high quality, and accessible for everyone. So it really merged or married two great institutions to provide us with the best evidence-based safe practices for our patients. So, I would be remiss if I did not tell you more about the Pediatric Pharmacy Association. I recently was the president of this organization, and I'm currently the immediate past president of it. But originally, this was actually founded as an administrators group. But now it has moved more to a clinical setting, and we have over 1,500 members. We do have a few international members, and we do have ways in which people internationally can now get involved with the Pediatric Pharmacy Association. And we really provide information for the clinical care of pediatric patients. And I think what's really important about the organization is we actually have 22 subspecialists, special interest groups, which help you connect to pediatric pharmacists around the world. And you can basically ask questions of various people that are doing what you're doing every single day. So if you don't have a neonatal pharmacist, a gastroenterology-based pharmacist, an endocrinology-based pharmacist at your site, you can ask others in your special interest group what they're doing and get feedback from them. We also have association liaisons, which are appointed by PPA to represent our interests, both within the American Pharmacy Association as well as the American Academy of Pediatrics, to help further our mission, which is to collaborate, advocate, research, and educate, and support the health and well-being of children in a safe and effective manner. Now, again, can't forget the International Pharmaceutical Federation, which has a true emphasis in presentations like today's on patient safety. And they recognize that there is an increasing need for pediatric specific information. As my previous presenters have mentioned, children are not just small adults. And so, how can we provide very specific information for pediatric patients as pharmacists? Because our pharmacist role is medication without harm. And so, how can we do that in the best possible scenario? So, with that, I want to charge you. What will you do? Where do you see yourself in solving the problem of patient safety for newborns and pediatric patients?
For that wonderful presentation. I particularly appreciate you calling out those organizations like ISMP, FIP, and PPA because they are so important in advocating for pediatric and newborn care. Thank you very much. Well, that concludes our formal presentations. And so what I'd like to do is invite our presenters to come back on camera, and we're going to conduct a Q&A session. As our moderators and hosts have been encouraging you, please do submit those questions via the Q&A box. And I'd like to start with the first question here, which I think is a really good one and one I often think about as well. And this is open to any presenter. What is the role, or what is your perceived role of AI, artificial intelligence, in helping maintain pediatric medication safety?
Shall I start?
Please.
Yes. Um, I think AI, talking about generative AI then, like ChatGPT, it could give us as pharmacists ideas about where to look for information perhaps, but I don't think at the moment AI can provide the recommendations maybe we are sometimes looking for. Because AI doesn't know things by itself. It's a language model. It's um, yeah. It looks into what would be probably the next sentence or word which is likely to be the next. Sorry, I think about it. Um, so I don't think AI is reliable enough yet to use it for those recommendations, but it can certainly maybe point you in the right direction if you know what to do and if you ask the right prompts. Now, FIP has developed a toolkit for pharmacists about the use of AI in clinical practice. So you can find more information there. And yeah, this can help you in how you can could use or could not use AI. I think what's important here is be aware of digital health literacy with regard to the use of AI, not only by pharmacists and other healthcare providers, but also by patients. When I was at the FAP Congress in 2025, a few weeks ago, I talked to a pharmacist I met there, and he told me patients here in my country, they ask ChatGPT for advice, then they go to the pharmacist and they tell him, what you said to me is wrong because ChatGPT says otherwise. So we need to be aware of that, I think, as pharmacists. Yeah, so digital health
Thank
literacy.
you. Thank you, Frauke. Yeah. And yes, there is that little disclaimer in ChatGPT at the bottom that says ChatGPT could be wrong. Please verify. So maybe a pharmacist is a good way to verify that. And Petria, would you like to add anything to Frauke's answer regarding AI?
Yeah, I think this is really one of those times where we don't know what we don't know all the time. And as a educator, what I find is ChatGPT can really lead you astray. You know, if you don't have enough information and knowledge about something, you don't know when it's telling you something it shouldn't be telling you. And so I find that we have to educate on when it's appropriate, when we realize, oh, that's not even close to what it's the true answer. And I find that really important for our trainees. So, our students, our residents, our fellows, and even our teammates, because sometimes you'll catch a provider looking at ChatGPT or a nurse or someone that's with you and basically helping them realize what's true and accurate and what is a less than ideal response. But 100% agree about the prompts. The prompts dictate everything. The better prompt you give, the better response you get. And there are a few sites that have some more evidence-based medicine. I know we've looked at OpenAI, and OpenAI can give you a little bit more information, but I'd still always be cautious of anything that you find in that manner.
Thank you. Very, very good advice from both of you. Shifting just a little bit away from AI, can either of you speak to how some strategies for how to prevent and potentially minimize antimicrobial resistance in our newborn and pediatric populations?
So, I mean, probably the biggest thing that I would think about. So, the Vermont Oxford Network, which is a huge collaborative in the United States, really has pushed this in the last years. And it's really knowing about your risk. So, what is the true risk? And we found that the risks weren't nearly as much as we thought they were. You know, you have a patient and they kind of look, might get sick, you are a little bit more likely to treat them than if they're looking well and they're looking fine, and but you're just scared in that regard. And so being able to have those risk stratification policies, procedures, protocols in place really helped us to see that a lot of our patients we would get responses back about their cultures within 24 to 36 hours. So why are we continuing things for 48, 72, 5 days when we know that with certainty 99.9% of them come back in 24 hours? And we were actually able to not only decrease the time on antibiotics, but also who actually needed those antibiotics through different protocols and procedures. So I think looking at your data and then coming up with a standardized process, but always being available to pull a quick trigger when you need to for a given patient scenario if they start looking very sick to you.
Great, great advice, Patria. Frauke, anything to add regarding antimicrobial resistance? I don't want to put you on the spot, but give you the opportunity.
Thank you, but I have nothing to add.
Okay, very, very good. Thank you. You know, we've had a few questions come across regarding or alluding to standardization in pediatric care as a safety project. If someone in the audience wanted to start their own standardization safety project, how would you advise them to start? You know, what are some of those first steps that they can do to go down that road?
For myself, I typically find that I consult the literature first. So, you don't need to reinvent the wheel. You can basically be able to look at what others have done and base your support on that discussion, and then talk to your colleagues in the area. And basically, you need to come up with some sort of framework, look at your system, and see what will work best for you, and talk to all the players within the system. So don't leave out different pieces and parts because the pharmacy may be able to incorporate everything, but if it can't be administered or the providers can't write for it, then you'll run into various problems.
Great. Okay, we have a question that I think is directed at you, so perhaps I'll start with you first. You mentioned this in your presentation, but for the audience, could you elaborate on health literacy and digital health literacy, specifically with regard to ensuring safe medication management in our pediatric population?
Yes, this was also addressed during the Health Literacy Summit we had previous to the FAP Congress. For caregivers and parents to administer the medication to their children, but also to see if the right medication is being prescribed, they need to be able to understand the instructions and to understand what medications their child is using, how to prepare this medication, and why prepare it in that way. And this went wrong in the case I showed you. The mother wasn't given the right instructions. The instructions were not clear enough. The mother didn't understand why she was adding the drug to the formula the child was using. And then it went wrong. So it's very important to give clear information in a language the patient understands, but also take into account with regard to international perspective, cultural differences, perhaps. And then take into account health literacy is not entirely the same as digital health literacy. If you provide the information digitally, then you need to make sure the patient is able to use the device in which to watch it or to read it, and that the patient knows how to use the digital tools. Well, we just talked a little bit about use of ChatGPT by patients. If they don't understand what AI really is, that it can be wrong, that it depends on what prompt you use, what answer you get. Yeah, then it can go, there can be mistakes. So.
Thank you, Frauke. And I believe there are some FIP health literacy resources in this area as well. Can you elaborate on how to obtain or access those resources?
We're currently working on resources specifically for pediatrics and pregnancy. The working group has just started, and we are first going to identify the needs which are there. But there is some knowledge about health literacy in general available already from the Health Literacy Summit. And if anyone would like to have more information on that, please contact the Health and Medicine Information section. The contact information is on the FRP website.
Well, thank you, Frauke, and the health information section for your great work in that respect. Patria, I'm going to turn to you, and certainly Frauke, if you want to add to this, I welcome it. But based on these excellent presentations, I'm sure you've motivated a lot of those in the audience around getting involved. So can you outline a few steps or a few ways that our pharmacist colleagues can get involved in public health initiatives related to the topics we discussed today?
I mean, I think the biggest thing is just find that organization that is in your area and, join. And I always tell, what I tell students and young pharmacists, join a committee that might be doing something that you're very interested in. And what you'll find first is that you'll find you're not alone. This isn't that you aren't the first person who had this problem, which I think a lot of times is kind of reassuring that you're not alone in this fight or struggle. And then together, you might be able to impact it in some way. And it may seem small at first, but it really can grow and take a life of its own in that regard. So I just say get involved, see what's out there, find like minds, and like minds tend, especially pharmacy like minds, they tend to get a lot done if they have a mission and a passion about it.
Absolutely. I couldn't agree more. Frauke, I keep turning to you afterwards, but I want to make sure you have an opportunity to contribute if you'd like.
Thank you. Well, like Patria mentioned before, don't reinvent the wheel if it's already been invented. So I totally agree. Find colleagues who can help you, who maybe encounter the same problems, have different perspectives on possible solutions, and learn from each other, both on a regional level, international level, and international level.
Yeah, well said, both of you. Thank you. Um, this question's maybe a little tricky. We all know that, and if we didn't know, we heard it loud and clear today that a pharmacist's value in a pediatric specialty role is immense, and there's a lot pharmacists can do for our pediatric and newborn population. Unfortunately, it's sometimes difficult securing funding to support those types of positions. Um, any advice on how to, for lack of a better word, sell the pharmacist service in pediatric and newborn populations to gain financial support for these really important roles?
So I think a lot of times you'll find that the what speaks the most, unfortunately, is dollars. And so when you show how much money you can either save or error reduction of some sort, that speaks volumes. The other one that I found to also be beneficial is meeting certain criteria, benchmarks, acknowledgement of some system. So, for say a residency program, sometimes when they come in to accredit you and they're saying, you know, you really could use a pharmacist in this area to continue the work you're doing, have them write that in the report to the C-suite, the administrators and the managers, because that means a lot if they see that this is something that an accreditor wants. Additionally, like I said, certifications, we actually found at my last institution being able to say that you are certified as this kind of trauma center or you can provide this type of specialized care. They often think of all the providers and nursing staff and technology and lab resources, but then they find out that there's actually usually lines in there that say you need to have a dedicated pharmacist that is there. And so we were able to leverage some of those because the hospital wanted to be recognized for those things to be able to get pharmacists. So not just dollars and cents, but try to find unique ways in which someone else is telling your administration that you need a pharmacist.
Yeah, great advice, Patria. And it is somewhat trying to find what are those pressure points, right, for the decision makers, and
Hmm.
we would call that the C-suite, but those like executives, the presidents, the vice presidents, and other leaders in the organization. That's wonderful. Frauke, would you like to contribute as well?
Yeah, I totally agree. And I also think it's important for pharmacists to be visible, be good and tell it, show the world what we can do and what we already are doing.
Yeah. Well said again. I believe that concludes the questions that we've received, but I want to turn back to our wonderful presenters, first to thank you, but also allow you any final thoughts that you would like to leave our audience with as we close today.
I think the biggest thing, I don't have to tell this group how important you are to the patients that you take care of every day. What I sometimes do have to tell people is, you know, sometimes as the pediatric pharmacist, I find that we take care of the patient, we advocate for them, but we don't always advocate for ourselves. And so, how we get more done is basically showing the good things that we're doing for our patients. We tend to be a little bit more reserved, I think, and we don't tell everybody of what we're doing. We want to make sure the team is recognized and all that, but sometimes we just need to put a spotlight on ourselves as pediatric pharmacists and really show what we can do and what we bring and advocating for our profession, because not only does it increase our numbers, hopefully we encourage a younger generation to join us.
Thank you. Frauke, any final thoughts from you?
Actually, I do fully agree with Patria. I think pharmacists can be a bit reserved, and it's important to show what we can do, what we can add to patient care, and have patients going to the pharmacist with their questions about medications instead of to the physician as a first starting point. Show physicians and policymakers and other healthcare professionals the value of the pharmacist, the added value. So I think that's really important also in pediatric care.
Uh, Absolutely. And again, one more round of thanks to Frauke, Patria, as well as Hossam, for your wonderful presentations and insight in this very important topic on what is a great day for our patients and celebrating World Patient Safety Day and ensuring that harm is a zero number, that we don't harm our patients and we care for them as best we can as our pharmacists. So allow me to conclude with a few closing remarks. First, check out all the FIP digital events at events.fip.org. There are so many wonderful programs, and I encourage you to visit that site to access them. I also encourage you, coming off of our wonderful Congress in Copenhagen, our Congress in 2026 in Montreal will be here before you know it. And the theme of the 84th FIP World Congress is One Health, One Pharmacy, Bridging Science, Practice, and Education. I will be there. I hope I see you there. I'm already excited to visit our friends to the north, for those of us in the United States, and hope again you make the trip and we see you in Montreal in 2026. As you prepare for the FIP Congress in Montreal, a few important dates are located on this slide. I'll call your attention to two. One is the abstract submission deadline, which is the 18th of March next year, 2026. The other is that early registration deadline. So I want to call that out. That's the 3rd of June, 2026. One final thanks on behalf of myself, Hanadi, and all the presenters. We truly appreciate your time and your attention, your engagement. Wishing you all the best for the rest of your day.